DCE right here. We are going to talk about detecting early and restoring minimally today, which are the buzzwords we hear in dentistry now, right? We're hearing it time and time again. Our patients are asking for it, and I think it's super important that we know all about it and are pretty well versed in it. Historically, as dentists, we have worked with the model of detect things after they've reached the cavitation stage. So we use mirrors, explorers, and radiographs. And when we use those, we are able to see things only after they get to a certain point, after our explorer sticks into that decay, and after we can see it on an x-ray, which usually means it's at the point where we have to fill it. Really becoming obsolete. Times are changing, and technology is making us better as dentists and allowing us to do better dentistry for our patients, making our patients healthier longer, and changing us from operative dentists to healers, more like the doctors that we were trained to be. Over the past several decades, we've seen big changes in the way we practice dentistry and what our patients expect from us. Preventive care has changed a lot of things in dentistry for us. And is it the same in Iraq as well? Yeah. And there's so much more awareness among the dental population of our patients that are coming in to see us. They have high expectations of us. They want us to have technology. They want us to be able to provide the best care for them. And all of these things together have resulted in a number of things. Big changes for us in dentistry. Lower caries incidences. So we see fewer and fewer caries in our population. Younger people have less decay. And when they have decay, they're smaller lesions. Now that's changed the way we look at our practices and how we move forward. Which is great news for us, like yay dentists. We are doing a great job, dentists and dental hygienists. We're doing a great job in changing the way of solving the disease that's out there, dental disease that's out there in the world. So less shots. Come on, I guess. Are my patients good sports? Less injections, less drilling, less taking away tooth structure, less restoring teeth in big ways, and more early detection and minimally invasive dentistry. That's a challenge for us as dental practitioners. We sort of have to change our thought process a little bit. We now have to ask ourselves, are the traditional ways of detecting caries still appropriate today? Is taking a mirror and cruising around the dentition the most effective way we could look for caries? Are x-rays the best way we can treat our patients? Ionizing radiation, is that something we want to try to avoid for our patients? And early detection means that we're finding these cavities earlier, we're finding demineralization earlier, and when we do that, how are we going to restore that? Do we have new options for restorations? What's the best we can do? How do we up our game dentally? Ultra-conservative restorations and minimal preps and bioactive materials. Our traditional diagnosis methods, we were all trained this way. We pick up our mirror and explore, it's in every single kit. We sit down with our patients, we cruise through the mouth, anything sticking. And then we take bite wings pretty routinely on most patients. Are you in your office every year or so? Every year we're taking bite wings on patients. Sometimes we're adjusting that if our patients have low caries index. Maybe we're doing it every 2 years. But for the most part, we're taking a lot of radiation. We're giving our patients a lot of radiation. And when we do those kinds of methods, we're really only detecting the kind of caries that are big enough to see. Stick with an explorer or see on an x-ray. And that means they're already past the point of just incipient lesions. They now need to be filled. We have to do something with those almost all the time. And they're looking like this. We see these kind, when we're cruising through the mouth, we know this is something we're going to have to fill, right? This is an absolute schedule them for an appointment, get them numb, drill them, and fill them. And the same thing here. This is a point where we have to do some dentistry on that, some serious dentistry on that. Our Explorer is a time-tested tool. We have used it forever. It's a standard part of care for all of us, and I'm not suggesting that we abandon the Explorer. What I think this technology allows us to do is look at things so much more closely and find things so much earlier and use it as an adjunct to our normal diagnostic procedures. Early detection back in the 1900s, and this isn't turn of the century that just happened. This is the turn of the century before that. So 2 turns of the century ago is when we started using Explorers. G.V. Black said, he diagnosed it, a sharp Explorer should be used with some pressure and a very slight pull is required to take it out, then you should mark that cavity as it needing to be restored. And if G.V. Black back at the University of Michigan decided to call up his colleagues and have a little chat about that, he would have picked up a phone that looked like that. And today we know that we all have microcomputers in our hands. We have all evolved in technology in so many ways, and dentistry is evolved in technology in so many ways. But caries detection has not taken hold. We haven't had the technology until recently to be able to really change the way we look at caries. When we take an Explorer and we cruise through the mouth, that Explorer only gives us an indication of pretty advanced caries. We can easily miss incipient lesions. It won't stick on incipient lesions. It cruises right by them. And some studies recommend that we don't use Explorers at all anymore. That we are actually causing damage to the remineralization process with our sharp Explorers. That if we have a tooth that's starting to demineralize a little bit, and you pick up your Explorer and touch that tooth area, it's going to actually do harm to the tooth. So what do we do about that? Radiographically, caries can be very difficult to diagnose until they hit to a certain spot. So if we see our Explorer, we're cruising around a tooth, I would cruise right by this with my Explorer. It doesn't feel any stick, I'm not going to do anything to it, but actually what's going on there is incipient lesions. And we won't see that incipient lesion until it gets to that spot. That's when you can see it radiographically and where it's probably going to stick with an Explorer. So what can we do to find that a little bit earlier? We're also dealing with the effects of fluoride. Fluoride has been great for the dental population. It is great for caries reduction. But what does it also do? It hardens the enamel on the surface of teeth, but there can be microdemineralization through the tooth, through the fluoride, and the dentin underneath becomes soft and brown. And I think we've all seen that, where you look at a tooth, you can't get a catch-it-all with an Explorer, but you can actually see the brown. You can see the brown underneath. And by the time you get to that, you've got a pretty deep lesion. And interestingly enough, correctly diagnosing what we call hidden caries, caries that have been hardened through fluoride, enamel that's been hardened through fluoride, we as dentists and hygienists only get that 12% of the time. So that means 90% of the time we are missing those caries. And that's not a very good odds for us. Correct clinical diagnosis of visible caries, we're getting better. We're like 62 to 90%. We're doing pretty well with that. If you can actually see it with your eyes, we're good. We're good at that. What's the benefits for our patients? Fewer cavities progress to cavitation. That means fewer times do we have to drill and fill our patients. We maintain the natural occlusion. We maintain the natural aesthetics. Overall, for our patients, lifetime reduction in dental care, dental caries, and dental restorations. So instead of a filling at 12 years old, an onlay at 30 years old, a crown at 50 years old, an endo crown at 60, and then an implant, we can prevent that. We can stop that cascade of events with caries. So we're going to miss a lot of caries if we're just looking with an Explorer and radiographs alone. And when we do that, when we use just the traditional methods, Explorers and X-rays, we have a couple of options. We can either diagnose decay, straight up decay, and we need to restore it. Or we can diagnose it has slight decay and then What's our option there? Well, let's wait and watch. We put a little watch on it, on our chart, and hope for the best. Hope for 6 months later that it doesn't get bigger. Cross our fingers and pray a little bit. Or if it's interproximally, we're taking x-rays a whole year later and seeing what happened, and what always happens. Most of the time is bigger. It's bigger. It's growing. Technology today. Technology has changed the way we can do dentistry, and it's pretty exciting. There's a lot of different methods of technology. We have illumination, we have fluorescence, electrical conductance. We take x-rays and we send them through software packages that allow us to see them better than we can with our naked eye, and allow us to evaluate them. I want to talk to you today about detecting the most important, comprehensively diagnosing through technology. So we want to diagnose the smooth surface lesions. We want to diagnose the pits and fissures, the occlusal lesions, and we want to diagnose interproximally. And that's what we've been using our mirrors, explorers, and x-rays to do all this time. This is a brand new, here in the U.S., advanced piece of technology that allows us to do all of those things at the same time. It is a camera that has 3 heads on it. An interproximal head, it allows us to see interproximally, and we'll take a good look at that. It has a head that fluoresces, that shows us the pits and fissures and the smooth surfaces, and it has an integral camera, all on the same sort of nimble wand. It's a total comprehensive diagnostic tool that's never been around before. Some of you may have these in your office, or you may have used other types of technology where you have a camera on one cord, you've got a Caries detector on another cord, another piece of equipment, and perhaps you have the interproximal transilluminator on yet another piece of equipment. This changes workflow for us, and for hygienists, my hygienist thought it was a dream come true. Really kind of exciting. The interproximal detection head is the newest part of this system. It's sort of a game changer. It takes us from just being able to see some parts of the teeth to see everything. It works with infrared transillumination. So when you turn it on, you don't see it. It looks like the camera's off. So if you get a chance to go over and take a look at it, I think you'll really enjoy seeing it and seeing how it works. So it's invisible to the human eye, but there's a small sensor inside the head that reads the reflected light. And carious lesions, when they're reflected, look cloudy, and the healthy enamel looks like glass. So very, very cool and very diagnostic. What's amazing about it is it can replace bite wing x-rays for many, many of our patients. So we can diagnose interproximally without ionizing radiation for them. Super exciting. So a few views using this camera. And you see here a healthy situation. The enamel looks like glass and the dentin looks whiter. Pretty easy and diagnostic to see. The next one down, incipient lesions. You can see those little white areas on either side of the interproximal space. And then as it grows, it gets bigger. And you see it's here, and you can read it in the dentin. And as it gets really big, you can see it infiltrate all the way into the dentin. So it allows you to calibrate really easily how far that lesion has progressed, and it allows you to take an image of it without radiating your patient. So if you have a patient that has that incipient lesion, you can decide, I am going to no longer wait and watch, but perhaps I'm going to use a remineralization product on this patient. And then in 6 months when he comes back, I can again take a photograph with this system of that area and assess, is the remineralization working, or is that lesion growing, and do I need to do something perhaps more invasive on that patient? But if we were going to do that radiographically, we probably couldn't do that. We wouldn't want to radiograph our patients time and time again to assess how far decay has evolved. In our office, our hygienist, this is in the hygiene room. So our hygienist, as part of a routine exam, new patient and recall exam, is using this camera. She's cruising through interproximally on all of the areas and capturing anything that she sees that may be of interest to interproximal decay. And for us, we are billing this like bite wings. So you're asking, well, what happens if we have this piece of equipment and then we used to go over x-rays? And that was a part of our production in our office every day. This camera, we bill it for x-rays, traditionally not covered by insurance that I've found, but patients are really excited and willing to pay the extra money to not have x-rays. I find that especially true for mothers of kids. I say to them, Mom, I have a technology that's going to allow me to see in between those teeth without taking x-rays. And it's going to cost in our office $48 to do that, but it's probably not going to be covered by your insurance. And she said, immediate response is, you're doing that without x-rays? I'm happy to pay it. Happy to pay it. How about this, the decay epidemic? We all seen cases like this where we have patients for years. We're taking x-rays on them and they have no decay. And all of a sudden they hit 16, 17, 18 years old and they have a mouthful of interproximal lesions. All of these teeth we're finding lesions radiographically on all of these teeth. So what do we do? Do we drill interproximally on every single kid? Are we deciding to do 30 restorations on this guy, even if we're doing them as small as possible? I don't want to do that. We're able to use this technology to calibrate which of these teeth as an adjunct to x-rays in this situation, which of these teeth appear to be just in the demineralization, just in the enamel, and which are further along and may need further attention. So we looked at the interproximal head, and then my hygienist pops off the interproximal head and pops on the spectra head, and that's the fluorescing head that allows us to see the occlusal surfaces of the teeth. It works through fluorescence. So oral microbacteria, the microorganisms in our mouth, they emit an orange-red phosphor when they're actively digesting in the mouth. And that becomes the marker of the degeneration of the tooth, the bacterial invasion of the tooth. We shine our camera on it and take a photograph with the camera, and all the healthy enamel fluoresces green, and where it's invaded enamel, where we have potential caries, it fluoresces red in general, and more specifically, with this camera, it calibrates it as to how deep it is. So you get a very good reading of healthy enamel all the way to these yellow parts. It calibrates it by color and by number. So super diagnostic tool to show patients, here's what I found in your mouth. I can show you exactly how deep it is and where I think we should do something really minimally prepped. Healthy enamel is green, incipient enamel, demineralization is blue. If we get deeper enamel, it's red, and then we get to the orange where we're into the dentin, and if it's deep into the dentin, we're getting yellow caries, and it's calibrated by number. So if you had a situation where you had incipient caries lesions, you have a little bit of blue on a tooth, you can decide for yourself. Clinically, I think I'm going to try to remineralize this tooth. It's calibrated at about a 1 or a 1.4. I'm going to send this patient home with a demineralizing paste for the next 6 months, and when he comes back, I'm going to shine a light on it again. And is it better, is it worse, or is it maintained the same? Super easy and really the best dentistry we can do for our patients, for sure. It does pit and fissure analysis, so we do smooth surface decay analysis. We also can look at decay that's occurring around fillings, so super helpful to show what kind of decay we have around fillings, and now we can detect interproximally with this device. Comprehensive diagnosis. And it goes from room to room to room. It's on a cord, you plug it in the USB port of your computer, and you can take it room to room to room. Lets us decide as clinicians, what are we going to do? Excuse me, I'm going to walk for my water. What are we going to do? We've used our technology to find incipient lesions. And now we can decide, how incipient are they? How advanced are they? How am I going to restore this? I'm going to restore it now. Like, that's a marker for restore it now. Am I going to try some remineralization therapy? Am I going to try to heal the surface of the tooth through remineralization? And am I going to monitor that? And it's not just a wait and watch. It's a calibrated, numerical, empirical value for that tooth. I know exactly how far it has gone and if it's improving or not improving. So the days of mirrors, explorers are sort of in the past. We are moving toward technology to let us be better dentists and let us do better things for our patients. I think this case is pretty interesting. When you look at the occlusal surface on the upper left side of that tooth, that is a tooth I absolutely would not have restored or looked twice at as I was cruising through a diagnosis, a 6-month exam. We hit it with a spectrum camera, and I get this sort of reading, and it says that there are decay in the pit, and if we were to open that up, we would be able to see that little bit of decay, that incipient decay, and that allows us to treat it early before it becomes a big cavitated lesion. How about our treatment options? We have had an evolution in dentistry that has gone from operative dentistry, drilling and filling, to minimally treating teeth and healing teeth the best with great new materials out there. And this is counterintuitive to a lot of us dentists, that we used to think that once a tooth demineralized, once it started to decay, there was nothing to be done to it, there was nothing that we could do but watch and wait as it continued to decay and decay. But it turns out the surface of the tooth is in a constant state of demineralization and remineralization. And that means when the environment of our saliva is acidic, when we subject it to repeated carbohydrate intake, we have poor saliva content. When it's acidic in our mouth, when we're eating a lot of sugars, then the calcium phosphate ions in the enamel leach out of the tooth. And if we change the makeup of the environment of our teeth, of our saliva, we make it more basic and fill it with calcium and phosphate, that calcium and phosphate leaches back into the enamel and actually heals. So it changes from demineralization to remineralization, and that's dependent on what the surrounding environment is, what our bacteria count is in our mouth, and the acidity and basicness of our environment that we're creating. Oh, it's jumpy today. So it's demineralizing. Our teeth are demineralizing. The enamel of our teeth, our patient's teeth are demineralizing when we have the bacteria there, when we have reduced salivary flow, and when we have a lot of frequency of sugary foods and acidic foods. And it's remineralizing when our saliva flow is healthy, when our saliva flow includes a lot of proteins and the calcium phosphate. And fluoride helps. And then there's remineralization products that help too. Demineralization, remineralization. A constant balance going on the outside of our tooth, back and forth. Products for remineralization. So we have this technology. We now see that there are teeth that we can diagnose early. We can find them when they are just starting to demineralize a little bit. We can find them with our spectrum camera or with our interproximal head. What do we do about that? What are our treatment options? The most conservative thing we can do, if it's just starting to demineralize a little bit, is that we can use remineralization products. We can prescribe or dispense to that patient products like this, MI paste, Reminpro, ACP containing paste, Novamin paste, fluorides. All those things change the environment of our saliva and change that balance from demineralization to remineralization. And this question always gets big. Well, how do I bill for that? What am I supposed to do with that? In our office, we bill for remineralization therapy. So we have a code that's also non-insurance reimbursable that I've ever found, but patients are extremely receptive to this. So we put them on a paste and then we monitor them with the Spectra camera. Usually 6 months. We monitor them in 6 months, and we can do it for a whole year as long as it's not getting worse. And then again, take another reading 6 months later. And we have a fee for that to do that. of those remineralization products. I use these products on lots and lots of people. Anybody that has any of these conditions, incipient caries, xerostomia, people that are on ortho, people that I've done a lot of cosmetic work on, a lot of crown and bridge work on, they really benefit from the remineralization products. It helps keep the margins of all our restorations intact, and also helps with the enamel on all those restorations. Minimally invasive dentistry. So we've got a situation where we've looked, we've examined our patient with our caries detection. We have found that they not only have incipient lesions, they have maybe just a little bit more. Their lesion is a little bit past the enamel. Something like this. What do we do with a situation like this? We could drill and fill, right? We could prep a cavity in there and fill it. Or we can use, we put our spectra camera on there and we can see that we have a little bit of demineralization that's all the way down into the dent. So it's a little bit past just leave it. It's not going to remineralize. We need something just a little bit more. We can use a system like a resin infiltration system. Super conservative, the most conservative thing as far as restoratively that we can do. This is a system that pulls resin down into the tube. So it goes from that to that. And we can smooth surface, I have a lot of success with this, infiltrating resin into the tube. This system can be used interproximally too. I personally have not had as much success interproximally with it, but I have seen reports of people that are very good with this system. Once again, probably non-insurance billable. And for me, that's a good thing because that's an elective procedure for a patient. I say to the patient, I think I can change that surface of your tooth. I can stop that decay process where it is by doing something minimally invasive, not drilling at all. I'm going to infiltrate resin down into that, and I think I can save you from having a cavity in that tooth. And that's something that our patients are extremely receptive to. If we get a little bit deeper. I don't know why we're so jumpy today with this clicker. So we've gone from incipient lesions to a little bit past incipient. We can infiltrate them. What happens if they're actual lesions? They're down into the dent. We've got to do something about it. I look at this tooth. I run the spectra camera over it. It gives me a reading of about a 2, a little bit of yellow down in that distal pit. And when I look at that, I look at the distal marginal ridge of that tooth. And this photograph was taken with the intraoral head of the Trident. So you see the quality of the image. It's pretty awesome image. It's very, very high definition image. But you see that distal marginal ridge. You're starting to think maybe that has a little decay in it. I'm wondering, is that tooth decayed? I've got a reading of about a 2 right here. But do I need to go and do I need to drop a box? Do I need to get in there a little deeper? Come on. There we go. And this is the image with the interproximal head, with our proximal head. And I see right here, I see a tiny bit of cloudiness. And you see all this beautiful clear enamel and a tiny bit of cloudiness here. That tells me that I have incipient lesions interproximally. And then I make a clinical decision that I am just going to restore the occlusal pit on there, and I'm going to watch that. I'm going to watch that with this camera every 6 months or every year and see if that changes. I'm also going to put this patient on remineralization paste because I want to keep that where it is. I want to do the minimum amount of dentistry I can do. I'm going to restore the occlusal pit because I know from that spectra reading that it's down into the dent. But from this reading, I think I'm pretty comfortable leaving the box, not decaying, not prepping down into the box. How do we do this as minimally as possible? Instead of taking our regular burrs on this, anesthesia and regular burrs, I'm going to use some physiotomy burrs. There's also abrasion. There are hard tissue lasers out there. These are the things that minimally take away an enamel. The smallest preps we can do. Physiotomy burrs are something I love to have around. The tip of these burrs are smaller than like a number 2 round burr. And you can typically use them without any anesthesia, and you can prep into fissures and clean out enamel and a little bit of dent without any anesthesia at all, and very, very conservatively. And we see how how the tips of these work. A fissurotomy burr, where I'm just removing the fissure, versus like a 330 burr, where you're undercutting and you're removing a lot more tissue away. You're also removing a lot of healthy enamel away with a 330 burr, which is standard dentistry, right? We all learn how to do it like that. So we've prepped the tooth minimally, and then we have to decide what to put in that tooth. And fortunately for us, we now have bioactive materials that allow us to prep minimally and perhaps heal the tooth a little bit from the inside. And what does that mean? Bioactive materials is another buzzword we're hearing time and time again. But all bioactive means is that it's eliciting some sort of response from the tooth. So if we put traditional composite or amalgam in a tooth, it's not eliciting any response. It's inert. It's like a space filler. We're actually filling the hole with that material. Bioactive materials release calcium and phosphate, and they stimulate some sort of response from the tooth. And typically that response is actual growing of dentin matrix. So really exciting for us, and a wonderful complement to detecting early. Small fillings, bioactive materials are going to go hand in hand. And ideally, these fillings will be bactericidal and bacteriostatic. They're going to stimulate the dentin formation, and they maintain pulp vitality. So these materials can do so many things for us. They're an alternative to traditional composites. So when we use traditional composites, we know that, and lots of great composites out there on the market, that they can be very strong, they can be aesthetic for sure, and they have a long track record. But they are passive, they don't do anything to the tooth. There's fillings like glass ionomers that are bioactive. They've been around for a long time too. But the downside to traditional glass ionomers is that they are not that aesthetic. They tend to be opaque and chalky, and they don't finish that well. But you know, glass ionomers will stick in teeth for a long time, and they'll leach fluoride, and they can arrest decay around that. Bioactive composites are the newest thing on our market, and you're going to see a lot of them here and a lot of them in journals and in the days to come, because they can be as beautiful as traditional composites, but they elicit a response from the tooth. They actually leach for calcium and phosphate into the tooth and stimulate reparative dentin. It's pretty exciting stuff. So we're actually healing from the inside out, causing those decay, like almost a zipper effect between the restoration and the actual reparative dentin. How about a situation like this? This is tooth number 31 on a new patient that just came into my office last week. Also another image from the Trident camera. And I think that image is really indicative of how well it captures detail. And this patient told me, that stain's been in my tooth forever. I've had that for a long time. And she was a youngerish patient, I think she was 22 years old, and said, no, I never get that filled. My dentist never said I needed anything done with that. And clinically, to me, that looks like a little bit of decay, but you can also see it could be some superficial staining. So we take a spectra image of that. My hygienist runs her spectra, pops off the inner roll head, pops on her spectra head, and captures an image of that. And it's a 1.5, so we're getting into deep enamel decay, not yet into dentin. So it's a perfect restoration to say, I'm going to perhaps do a fissurotomy on that tooth. I then pop on the interproximal head, and I want to take a look at the interproximal area. And it's kind of bright in here, so it's hard to see this, but it's perfectly glass and transparent the whole way interproximally. So this is just a buccal pit situation for me. I've ruled out the interproximal lesions for this patient. So I take a fissurotomy burr, no anesthesia, and prep it very, very lightly. And then etch, adhese, put a bioactive material in. And I feel like we've really done something good for this patient. Had we just left that tooth there the way it was, it could have developed into a much larger cavity, spread in the dentin much more quickly. Now I have a minimal prep restoration there that looks good and is stimulating reparative growth underneath that. And that's possible from all of the things that we're talking about this morning. So we want to detect as early as possible. That's the amazing thing about technology. It allows us to do that now. It's totally changing the way we're looking at teeth. Instead of that mirror and explorer and x-rays, I can now take a piece of equipment, a beautiful little nimble pace of technology and detect all the pits and fissures, detect all the smooth surfaces, pop the head off, go interproximally without taking ionizing radiation on these patients, and then if we need to, pop the other head back on, pop the camera head on, and maybe take some pictures and have a total patient education system. And I think for us, like, it's very competitive out there in dentistry today. There are lots of dentists around. There's a lot of advertising for dentists. A lot of our practices, we're all competing for new patients, and new patients are driven by several things. They're driven today by reviews, not just word of mouth from other patients, but online reviews and sites like Yelp and Facebook, and there's a lot of interaction between patients, friends, and family talking on social media. And when patients come into our office, a new patient comes in, we can have the experience where the patient has an exam and a cleaning, the regular kind of thing that we've always done, traditional dentistry, and they get up and say, yeah, that was a nice doctor, I liked her a lot, she was nice, her hygienist was nice. Or they can have an experience where we're showing them our technology and saying, teaching them a little bit. We have technology that allows us to see cavities that are just getting started, far before we could ever do it before. And this technology is light driven. So I'm shining a light on there, and then I'm shining an infrared light. And I'm going to take far fewer x-rays on you. And I'm going to show you my results. And I'm going to calibrate that and put them in your chart. And I feel like patients are sort of blown away by that. They are thinking, I've come somewhere special. I'm at a doctor's office that is doing the best thing for me. They're passionate about keeping me healthy. And it moves us from being kind of drillers and fillers into healers and moving toward healthier teeth and gums. You know, I showed you what that looked like before, and it'd be great if you go over and have a look at that. I think you'll really like to get that in your hand. It's very nimble and small. It has calibration on it, so you can get the same pictures every single time. And it's super easy to use. Instead of switching from one piece of equipment to the next, or perhaps purchasing 3 different types of equipment. And it does the pits and fissures. It does the interproximal. You see the lesion there? And it allows us to minimally prep. So we have options. We now can do the best dentistry for our patients. We can decide to remineralize. We can infiltrate with resin if that's appropriate, or we can minimally prep and fill with bioactive materials where we stimulate reparative dentin. And it's changing the way dentistry is done today. Detect early and restore minimally. Thank you for your time. Really appreciate you being here.